Gentlemen, we and big applause for the Dr. Young Jun Cha.
Thank you
So now the stage your.
Thank you for your introductions, and it is my great honor to be here as a speaker. And today I'm talking about our strategies for the interventions for the space closure and space management for the patient who has congenital missings, especially for the growing children. And how about the prevalence of the missing? From the meta-analysis, it was reported the wide range of missings from 6 to 7%. But interestingly, in the lower studies from the Judy Chang's and Korean University, we are higher prevalence of the absence, up to 11%. And most frequent absence area is mandibular incisors and premolar. And those two are highly strongly associated with impacted canine and peglateralis. And when you face a patient who have a congenital missing, you have two considerations. You have to decide between space closure and space regaining. You may decide your optimal treatment planning based on aesthetic, function, and limitations. And with the help of mini school, now easily you can make your treatment plan in reality. So, how about the outcomes from the dental implants? It is old study from the prosthodontic journal, and this journal show that compare many kind of oral rehabilitations from dental implants and conventional prosthetics, orthotransplantations, and the preservation of the primary molar. And they conclude that only rehabilitations by dental implant show the better general outcomes in terms of survival rate, success, and quality of life, and self-esteem, and the chewing function. In detail, the success rate of implant pretty high among all kind of approaches, up to 95%. And also satisfaction of patients, also most highest, up to 93%. So this is why the most of dentists prefer to dental implants. But in this study, did not include orthodontic space closure. So in my presentations, we will cover the aesthetic outcomes for each missing tooth from incisor to the premolar, and we want to compare between implants and orthodontic space closure. And here is our digital-driven orthodontic treatments protocol. So when you face the congenital missing teeth, I prefer to apply a virtual simulation to make a realistic treatment plan, and it helpful to make it more efficient for the patient treatment outcomes. So I'm show the first implant case for the missing on the lateral wrist, and he's a 12-year-old boy, and he was complaining about his tooth, ugly tooth. And when you see his mouth, we can notice that there's a peg on the right side and the midline deviation. We also can see the mild crowding on the mandible. He was class 1, and we found that there are 3 tooth missed, and the lateral incisor and the canine on both sides. So definitely we try to reduce number of implants, and we plan for the single implant upper lateral incisor, and maybe you can legend buildup on the peg lateralis. And at the same time, we need to distalization on the mandible. So this is very helpful to also correct the midline deviation. So we can see realistic tooth movement by virtual simulation. So only 1 or 2 millimeter of the protraction of the posterior segments is pretty realistic. And here's a progress. And we consolidate the space for the implants, and we finish digitalization of the mandible. Here's final. And after finishing case, he's only 16. We have to wait more than 3 years. So you have to consider about retention protocol. We have a choice, removable and fixed. In this case, we used fixed type because the boy, they don't like normally removable appliances. So we applied a more longer mini screw with the thicker. So we call it mini implant supported panning. So we don't need the patient compliances. And let me look at the alveolar bone. The retention protocol is helpful to maintain the space. Also, you have to preserve the patient alveolar bone. So the alveolar bone of the incisor always vulnerable. In this case, it's not big enough for the implant. So we try to keep it this alveolar bone, and I think it might be helpful to maintain their bone from this screw. And here's after installation of the panics, and after 2 years later, we replaced by the implants. So his final restorations, and when you look at the implant side, it's pretty aesthetic. And periodontists, they apply some gingiva graft on the cervical area. So how about result after 6 years later? This is 6 years later. As crown looks good and little bit gingival discolorations. But another thing is gingival recession on the premolar. So when you're thinking about substitutions, you have to aware about the gingival recession and cervical abrasion. So you have to guide the patient to toothbrushing very carefully. So in this case, we know that distal simulation is helpful for determine space redistributions, and also you have to make your retention protocol because you have to wait more than 2 or 4 years. So we can choose removable fixed type of retainer depending on patient ages and patient compliances. So I showed some mini implant supported padding, and first case, this approach is already introduced by Dr. Wimmis and Dr. Messens more than 10 years ago. And they show different type of the approach, and their success and stability is quite different from 2 years up to 10 years. So we need more evidence about stability of this kind of supportive temporary padding. But I think it is helpful to maintain space. Also, it is helpful to maintain the alveolar bone quality and quantity, which is make easier for the future implantation with the minimum operations. So we moved the lower incisor missings. He is a 70-year-old male, and his complaint was anterior crossbite. So negative overjet, and you can see 3 incisor on the mandible, and you can see also space behind the canine. The patients want a facial profile, change of facial profile, because he was severe class 3 with the mandibular prognosis. So we definitely suggest surgical approach. So first option is make the space for the missing area, because we need to correct the inclination of the incisor. If you proclination of the incisor, it is helpful to improve the facial profile. We can increase mandibular setback. So this setup will show that without the distalization, we can make enough space for the lower missing area. So we plan for the mandibular setback around 12 millimeter, and we make the space. At the end of treatment, we know that we could make enough alveolar bone width and enough alveolar bone height, I thought. And here is a change of the profile after surgical approach. And finally, we placed the implants by periodontist. How about the frontal view? Are you satisfied? Yeah, he looks good, but when you look at the gingiva, you have to oil about discolorations. After 3 years later, how about the gingiva? they're getting darker. So missing on the mandible, we have to care about alveolar bone. There's a higher prevalence of discolorations. So in this case, in the lower missing, when you decide the treatment planning between space closure and the space opens, we are thinking about facial profile and the inclination of lower incisor. And if you decide the free incisor, it may be bad occlusion. So to optimize canine molar relationship, I recommend use digital simulation. And if you try to open the space, you're also thinking about quantity and quality of the alveolar bone. I show another case, the implant on the mandibular incisor. After 6 and 7 years later, we can see supra occlusions of the lower incisor. And here's a 7 years later, he complained about marginal incisor discrepancy on her incisors. And we can see some inflammations and discrepancy of the incisor level. So we have to change the crown, but she didn't know she needed additional crown in the future. So there was a claim about this issue. So from these two cases, we have two problems from the dental implant. First is discolorations, and second is improper position of the crown. This discoloration is from the insufficient alveolar bone on the buccal plate. So why there is insufficiency? It was studied from University of Connecticut, Professor Uruguay, and he compared alveolar ridge width and height change after orthodontic space open. They compared to the control side, and they found that the alveolar bone width still insufficient compared to control. There's a loss of the bone around 30% in their width and 12% in their height. So even though if you make the space for the implant, you have to know about the bone is not enough, including missing tooth. In addition, when you make the bone and open the space, can you preserve the alveolar bone? Most of the case, you have to wait a couple of years, sometimes more than 4 years. And during the time goes on, alveolar bone, their depth and their width and their height also decrease up to 2% and 4% annually. So even though you can make the bone, this bone going to be getting reduced. So if you lose the bone, but if you plan for implant, it is a worse story. Discoloration, sometimes bone descents. So very difficult on the lower incisor missing. And the other issue is improper position of the crown. We can commonly see because dental implant for missing incisor, we apply dental implant in only adults. So only adults, their slow motion rate is 3 times higher than older age. It's around 1% annually. So for example, if you crown in the early adults, after 4 or 5 years, their incisor discrepancy more than 0.5 to up to 0.7. So which means some cases we have consider about the crown. So we have to instruct the parent, their patients and their parents about this issue. This is another case, missing incisor. We put the implants when he was 19, and we follow up the 5 years, look at the retention. Crown looks good, but there's an improper position around 1.5 millimeter. And he claimed about this crowns, and we have to plan for next second crown again. So what our solution? Yeah, dental implant is the best option, but you need some alternative. She is also missing on the mandible, and we make the space, but not the implant space. We just apply conventional Maryland bridge. Look at her bone. Their convexity in this area is very concave, so which it does not include implants. So look at the outcome compared to the dental implant on the right side. So there's no discoloration. The traditional one is sometimes good. And her smile, we cannot see the discoloration anymore. But there's also a problem because of failure. Only the expected failure. Their risk is failure, around 30% within 5 years. So nowadays we recommend one wing cantilever instead of the double wing cantilever bridge because a higher success rate using the one wing up to 90%. So it can be one of the options. How about this patient, 22-year-old? He had two missing on the mandible. You cannot make a single cantilever bridge here. You have to place dental implants. How can you make the great outcome? So in this case, we need the periodontal, you need some special consideration in the periodontal surgery. We need a special care, such as a guided bone regeneration. With the help of autogenous bone graft, including bone morphogenic proteins, we can increase buccal alveolar bone thicknesses. Look at the huge amount of the buccal bone. So after operation, we can place two implants on the mandible without any recessions, any discolorations. And after 4 years, we did a wonder on the mandibular gingiva and 10 years retention. It's quite stable. So we are orthodontists, but we have to know about other approaches. So we need to collaborate for the better outcomes. So now we show the orthodontic space closure. Here is the incisor missing. She is a 7-year-old female. She complained about anterior crossback. And there was missing on the laterals, and also we can see the peg on the maxilla. So from panoramics, you can see the missing lateral incisor, the right side, and peg. She was class 3. And we planned for the correction of anterior crossbite by face mask. In this case, maybe we are planning for space closure for the future. So when you apply orthopedic first, I recommend oval corrections. So we make the oval corrections and make a class 1 and waiting for her growth. And this 14-year-old, we starting second phase, she still have a large overjet. So we have a choice. We can close the space after extraction of the pegs. Here, the patient's mouth, the missing space almost closed. So you have a choice. What's your choice? Do you want to open the space for the dental implants or protraction of canine? But protraction of canine is away from the symmetry. In this case, we have two choices: open the space or extraction pegs and closing space. It is also helpful to correct the midline deviations and make them more symmetric. So we have two choices. One is asymmetry, the other is symmetry. So first, we make the space for the dental implant. By simulation, if you want to make the space for dental implant right side, we have to plan in more than 4 millimeters of distalization. Sometimes, we cannot make it. It's too much distalization. So instead of the first plan, we decide the extraction of peg, and we just space closure and protraction of the right segments around 2 millimeters. And we're planning for the class 2 molar relationship in this case. So here, open the space for the premolar eruption and the space closure of the incisor. And to improve the incisor exposure, we wear she wear the elastic. And this is the final outcome. And here is occlusions. So we make the symmetry and the 1-year retention. So we are ready for final restorations for these patients. And this case, when you see the unilateral missing on the maxilla, we have to pursue symmetry. And by virtual alignment, you can choose most effective treatment option. And if you plan for the space closure for the future, you have to thinking about oval corrections, overjet. So it is helpful to next in second phase for the extraction of the abnormal tooth. And this case also similar, 7-year-old boy, and he also complained about anterior crossbite. We can see them 2 teeth missing, upper lateralis, and also he had pegs on the right side. Pegs and hips missing always come together, and there's one more missing premolar. So he was class 3 tendency, and we plan for removable appliance and face mask. Then we are monitoring patient's mandibular growth. At this time, we are concerned about extraction of the peg. So we have concerned about overcorrection. So here is the anterior crossbite corrections, and then after extraction of peg in all these stages. After that, we checking the growth of mandible, and mandible grows huge. So we plan for second phase of the face mask. This is helpful to close upper space, but not completely. So after protraction of the upper dentition, we can protract the canine at the same time with the face mask. Right first, only during night. It is helpful to close the space, because at this time we can now apply V-screw. Their failure rate pretty high, up to 30%. So we just use face mask. After canine close space closure, we cut the supporting of the premolar and continue to protraction of the premolar. Then by this process, we can completely close the space and protract the whole dentition of the maxillary. Then we are waiting for the second phase, because he had still mandibular deviation. So after extraction of the low premolar, maybe we can change his overjet and try deviation for the future. So we can see the nice parallelism of the canine and premolar. So we are waiting for the second. In this case, for the missing on the maxilla, early detection and early incision is very important, and also purchase and symmetry. And if you plan for some orthopedic appliances, we are thinking about this approach is helpful for space closure or space open. So we can decide when you apply the kind of appliances at the same time. So move to the lower incisor, 3 incisor. She is a class 2, 10-year-old. She complained about upper protrusion and congenital missing. Large overjet more than 9 millimeter and 3 incisor on the mandible. And this case, yeah, we are thinking about extraction upper bicuspid. Class 2, protrusion of the incisor. But she's still growing. We have another choice. A 3 incisor, class 2, very tall. In this case, we can apply some functional appliances with the headgear. Then we can check the mandibular growth. It is lucky. The response is pretty good. After 9 months, mandibular growth is pretty favorable. Then we can make an edge to edge. So we try to make a shallow overjet. We need to overcrack for the future space closure of the lower space if you want to make a 3 incisor. So her mandibular growth is very good, and make a class 1 relationship, a class 3 tendency, right? And we just make it with the 3 incisor. Really good, favorable mandibular growth. So here we have some lessons. If you decide 3 incisor or mandibular missing, we have to check the patient's skeletal pattern, AP discrepancy, and checking the potential growth of the mandible. If you decide 3 incisor, you have to check the 2 side discrepancy. Lower incisor must be larger than normal side. If it's small, you have to consider about restoration. So how about 2 incisor missing? This case is very interesting. She is 9-year-old. She complained about high canine and 2 incisor missing on the mandible, and class 2. High canine, and you can see supernumerary tooth on the maxilla, the same side, and lower space because of 2 incisor. So she was class 2, and the 2 incisor on the mandible. Maybe you can expect better extraction upper. But patients and parents didn't want, because already two incisors missed. They want to survive. So this case, I treat the transplantation. We can use supernormal tools, and you can move to the lower dentition to make a 3 incision. So here is a virtual alignment, and we decide to use supernumerary tools with the transplantation. So first, we try to open the space to mandible, and second, we bonded the brace upper, including the target tools, which is helpful to activate periodontal tissue regenerations. And after 1 month, we had tried 2 transplantations and pretty good outcome. And she still had a protrusion, so she wear the headgear, and also we did some maxillary expansion. This is a prognosis after transplantation. It's pretty good. She had a very small size incisor, so we still consider about resin buildup on the incisor, so we did it during the leveling. So here's a final with the 3 incisor. And lucky, mandible grows very well, so smiles get better and profile get better. So very favorable mandibular growth. Look at the retention after 2 years. So there's no discolorations, no gingivalization. Let me move the premolar missing. Premolar missing is also kind of opens. And one of the best options, single implants. It is clinical guideline from ADA, because single implant high success rate up to 95%, more than 10 years. So we try to maintain the mandibular space. Even though there's only exfoliation of the primary molar, we can open the space and make a bone for the dental implant. So normally implantation on the mandible, there's no problem. So this case, what's your choice? If the patient is 14, their primary tooth already exfoliated for some reasons, and he wants to treat his infection of the second molar. From the panoramic view, second molar is impacted, and he was class 3 at the time. So parents just wanna treat the infection, and they're gonna thinking about implants after adults on the mandibular missing area. So in this case, we just the traction of the impacted molar with the screw, and we protract and finishing the levelings and unlinings. Here's final. So we look at the patient wearing the maintainer, but he did not wear. So a couple of years later, he came back for the second phase. Space, 40% space closed. Now, what's your choice? First is dental implant. How about the age 18? Do you want a dental implant? It's quite narrow. Maybe thinking about orthodontic space closure, but you have to be aware about interradicular space. Most of tooth movement is dental tipping. Their radicular space quite large, is more than 8 millimeters. How about the bone? I was surprised. When I take a CBCT, their bone quality and quantity are quite different. Look at the thickness and density. Their alveolar bone get thicker and get more high density, which means it's difficult to protraction of the molar at this time. So I explained this issue to the parents. So we have 2 options anyway. Space regaining or space closure. But parents insist, doesn't want to implant anymore. So we decide to space closure. We can do with the half of mini screw. The problem is, it is too late, because already alveolar bone is showed high density and very thick. So we can, but there's a long time of the treatment, more than 3 years, almost 3 years. So we make root parallelisms, and the patient show the mandibular growth during even the second phase. So in this case, we can use retraction of the low incisor. At the same time, we can probe the molar. This is why it's more easier. In some case, we need the 100% protraction of the molar. It will be a tough case. So if you decide to extraction primary molar, we need to early decision for the missing on the premolar. This patient is for premolar missed. The patient came to my office because of the molar locking here. So to unlock the impacted molar, we decided extraction premolar first, and first molar eruptions you can see. And when the patient 10-year-old, we have decided extraction of the primary molar. So in this age, we extracted primary molar. And within 1 year, most of the space closed. It's very fast. Normally, 1 year later, 50% space closure. And 11, 13, 14. You know, right side, left side, a little bit different. Right side, their roots axis is getting better, but left side, there you can see only tippings. So we have to need additional also treatments. Anyway, these patients, lower space automatically closed, and by early decision of the primary molar. So here is the first and the final. For the first phase, we only use 2 removable appliances. First is median screw and AP screw. There's no more orthodontic treatment. Only we decide the time of the primary molar extraction. How about the unilateral missing? Here's 9-year-old and unilateral missing on the mandibular premolar and severe crowding. Look at the overbite, and there's no space for the canine. This case, you might be extraction of the premolar. This is helpful to close the missing area too. So if you decide only extraction, you have to convince about the extraction of the premolar, the other side. Patient have a deep bite, so we worry about only extractions, but class 1. So we decide to all extraction primary tooth or premolar. We call it serial extraction. Mandible and maxilla. So mandible you choose second premolar, maxilla is first premolar. So first, before the extraction, we started disking of the primary molar, and we allow the distal tipping of the premolar. Then the extraction of the primary molar and second premolar. So space was automatically closer, and maxilla will also extraction of the first bicuspid. This is after extraction 1 year, 2 years. So axis, if you decide only axis, get better. So here's change. There's a mandibular growth. It is good for the deep bite. And when the second phase, patient have a similar overjet and overbite. So even though primary molar extract only, it doesn't affect on the overbite. So second phase, we starting the second phase. Very simple, because we don't need to extraction anymore. Just correction overbite and crowding. It takes 2 years, and yes, we can crack the molar axis. And here is a skeletal outcomes. Now, he was almost class 3 because of mandibular growth. So which is promote the facial profile changes. I think it's better than initial profile. So I show some many cases, and it's time for the summarize our story. And first, how about outcome? Aesthetic and function by orthodontic space closure. This is our field. They investigate 1,000 papers, and they choose 9 control study, and also conclude that space closure is ethically and better functions compared to the prosthodontic replacements. Some cases, maybe we have to make a class 2 and class 1 relationship. It does not show any relationship with the occlusal function or with sign or symptom of the TMD. How about periodontal situations? This study from Europe, Dr. Schneider, she compared the periodontal condition between implant replacements and space closure. She monitored long time, more than 5 years, and compared their periodontal condition. The gingival recession and the pocket dubs is her major outcome, and the gingival pocket depth is quite similar between two groups. However, there's one thing difference is gingival recessions. Recession pretty high, and also take space closure case. Yeah, I already showed first case. There's a great possibility of the recession when you decide to space closure, especially subdivision of the canine. So, how about the premolar? I suggest only decision of the extraction of the premolar. It should be done within 11-year-old, at least before formation of the second molar. So if you decide early stage before 11-year-old, we can expect the major growth. But after root formation of the mandibular second molar, we have to expect major tipping. So timing is very important. And when you do early extraction of primary tooth, we have to know about advantage and disadvantage. First, space closure. Most space closure within 4 years, they're 80 to 90%. And they're inside the position, most of the case unchanged by previous study, which means it can reduce the need for the orthodontic treatments. But there's a disadvantage. We have a worry about it causing steeper come-up speed. And also they show significant tipping mandibular first and premolar around 6 to 12 degrees, which means we require additional orthodontic treatment. How about the effectiveness of treatment between two methods? One is only extractions, the other is late space closure as a single phase. My departments, I just doing the pilot study, and it showed that space closure is much shorter in early extraction groups, around 8 to 9 months. And total treatment duration also shorter than the rate one-phase space closure groups. So it can improve effectiveness of treatments when you decide the early extraction of primary molar. So here's conclusions. I introduced some strategies for early decision, for the space management, for the growing patient with congenital missing. We have 4 points. One is you need to make a patient recognize aesthetic limitation associated with the dental implant. And we need to promote the inside symmetry by early extraction of abnormal tooth. And we need to overcorrect overjet by applying orthopedic appliances. This is helpful for the space closure in the future. And the final thing is try to facilitate major drift of the molar by optimally timing the extraction of primary molar in case of missing premolar. Thank you for your kind attention.
Thank you, Dr. Yang Chun Cha.